Okay, then I start now. Assalamualaikum and good morning to Dr. Tan as well as colleagues. So today for our pain CME, I'll be talking about pain management in patients with vascular disease. And this is actually based on a review article that was published in the BJA in 2016. So when talking about vascular diseases, there's a wide range that is under the umbrella of vascular disease. But importantly, we have the arterial and venous disease, which the arterial disease is the peripheral arterial disease and the aneurysms. And for the for the venous disease that can present with pain can be the varicose veins. And for other kinds of vascular diseases include Burgess disease, Raynaud's phenomenon, CRPS, as well as thoracic outlet syndrome, which can be a combination of both arterial, venous, as well as neurologic. So when talking about outcomes in vascular surgery, a lot of the studies discuss about outcome as regards to cardiac disease. So then the issue is what about pain? Okay, so not a lot of the studies actually discuss about outcomes as regards to pain when it comes to our vascular patients. So there are many issues that are concerning regarding the pain management. One is the fact that pain itself is a key feature of vascular disease, and the pain can be severe enough to impact on quality of life as well as function. And this is especially true when you look at patients who have peripheral arterial disease. And many of these patients can have pre-existing chronic pain even before they present to us anesthetists or before they present to surgery. And a lot of these patients, especially the peripheral arterial disease patients, they can have multiple comorbidities. So, like I said, a lot of these patients can have multiple associated comorbidities. For example, like chronic kidney disease, obesity, diabetes, cognitive impairment, and heart disease. And this will impact on how we are able to manage the patient's pain as well as anesthetic management. And a lot of these patients can come for multiple surgeries. For example, those with peripheral arterial disease, they can come for multiple surgery ranging from just wound debridement to revascularization to amputation. And another thing is that as regards to vascular disease, uncontrolled pain is itself detrimental for the patients, as I will allude to later. So what are the mechanisms of pain as regards to these vascular patients? So it is actually multifactorial, and different diseases have different mechanisms of pain, and they can be roughly divided into nociceptive, inflammatory, as well as neuropathic pain. But a lot of these conditions can have a combination of all three mechanisms of pain. So nociceptive pain is the typical kind of pain that we see in our acute pain patients. So they can be from stimuli, for example, thermal, chemical, or mechanical injury towards that is detected by the peripheral nociceptors, which can be the C fibers or the A delta fibers. And these are based on peripheral receptors, which are located on the nerve endings of these nociceptors, which can be for example, the ion sensing ion channels, as well as the TRP channel family of channels. And they respond to either real or threatened non-neuronal tissue damage. And this is the normal adaptive response of the somatosensory nervous system. This is the normal response. You have a cut on the tissue, and that will lead to sensation of pain. So typically nociceptive pain is reversible, but they can be involved in the conversion to subsequent chronic pain states. So then the other mechanism of pain is inflammatory pain. And this is the response of the somatosensory nervous system to tissue damage, which can include surgery as well as general inflammation. And the inflammation that occurs at the nociceptor level will lead to accumulation of inflammatory mediators, for example, cytokines as well as chemokines. And this will lead to sensitization of the nociceptors. And this will lead to subsequent lowered threshold for responsiveness, and later on lead to potential stimulation of pain pathway, which can be manifested as allodynia or hyperalgesia. And this kind of inflammatory pain involves interactions between the peripheral immune cells, and there can be interaction with the local blood flow as well as changes in the chemical and electrical activity of the peripheral afferent neurons. And just like nociceptive pain, it is generally rapid and reversible, assuming that the wound heals properly. However, if there is a maladaptive response, and this will eventually lead to the conversion of acute pain to a chronic pain state. So this is a general overview of inflammatory pain, where you can have the interaction between the immune cells and interaction with the phenomenon of neurogenic inflammation, and this will subsequently lead to accumulation of chemokines as well as cytokines. And this not only from the immune cells, but you can also have this just from tissue injury, for example, direct tissue injury or inflammation or even infection, for example, like Staph aureus. And all these mediators will act on the receptors present on the nociceptors, and then this will lead to subsequent increased neuronal excitability. So then the third mechanism of pain is neuropathic pain. So neuropathic pain is in general is a pain that results from a lesion at the somatosensory nervous system, which can be at multiple micro as well as macro levels. For example, at the molecular, cellular, or even at the tissue level, from the peripheral as well as the central level. And this will lead to changes in the function and structure of the somatosensory nervous system, and leads to subsequent positive phenomena, which can be manifested as allodynia or hyperalgesia or hyperpathia. And with chronic pain presentations, it is the neuropathic mechanism which is the predominant mechanism of the presentation of pain, especially when you have patients, for example, with critical limb ischemia. So they can have chronic pain, and but then there's another issue in these critical limb ischemia patients, in which whether the pain that they have, is it true neuropathic pain, is it inflammatory pain, or is it post-surgical pain? And therefore, these are things that we have to look into when we assess our patients with vascular disease who have chronic pain, which kind of mechanism is the one that is generally predominant. So on top of the changes of the neuropathic pain caused by the peripheral and central changes, there can also be autonomic dysfunction present in neuropathic pain, in which there can be this so-called sympathetic afferent coupling. And this can be in many different ways. For example, there can be on the nociceptive neurons, there can be expression of adrenergic receptors, or at the dorsal root ganglia in the spine, there can be sprouting of sympathetic axons. And another thing is that at the local tissue level, increased inflammatory mediators can be maintained by sympathetically induced local vasoconstriction. So that itself will cause further nociceptor activation as well as sensitization from the local inflammation. So this sympathetic afferent coupling can cause central sensitization and lead to manifestation, for example, CRPS, and can also be attributed to in the manifestation of phantom limb pain. So this diagram will demonstrates the general areas where there can be changes that can lead to subsequent neuropathic pain. So the changes can occur either at the periphery level, or they can occur at the central level, at the level of the central nervous system. And this can be either from increase in the receptors, or in external damage leading to denervation injury and subsequent changes after that. And so this one is at the peripheral level, but at the central level there can be other changes in which there can be changes in the neurons as well as the glial activity, which can lead to promotion of a chronic slash neuropathic pain state. So this table is relatively useful in the sense that it describes the various vascular diseases, as well as the postulated pain mechanisms that are involved in the disease. For example, in those with peripheral arterial disease, so earlier on they can have nociceptive pain from intermittent claudication, and then later on they can have ischemic pain, especially when they begin to develop critical limb ischemia. And then even later on, the ischemic pain can later develop into neuropathic pain as it converts from acute to a chronic pain state. While AAAs, they are relatively nociceptive pain because related to surgery. So, and then for carotid artery disease, they are usually pain-free unless if they have already developed a stroke. And the kind of pain that they develop is generally nociceptive after surgery, but usually it is not as significant as aortic aneurysm surgery. Then for varicose veins, early on it can be nociceptive, but it can also be combined with inflammatory as well as ischemic pain. So for CRPS, it is generally neuropathic, which can be with or without autonomic involvement, and they can also be inflammatory pain. So it can be a combination. And then while for thoracic outlet syndrome, it depends on which kind of pathology it is predominant in, whether it's arterial, venous, or neurogenic thoracic outlet syndrome. And then for phantom limb as well as stump pain, so it is generally neuropathic, which can be with or without autonomic involvement. So next we go to some procedures and some conditions as well, and we go through what have people been studying regarding the pain management of these conditions. So acute vascular surgical pain, there are generally 4 procedures for which they are significant. Number 1 is aortic aneurysm repair, and then carotid endarterectomy, revascularization procedures, as well as limb amputation. However, when it comes to aortic aneurysm repair, like I mentioned in the introduction earlier, a lot of the focus is on cardiac comorbidities and not necessarily on pain. So people are more worried about whether the patients survive the condition and surgery rather than the post-op pain outcomes in the survivors. Of course, when it comes to open repair versus endovascular repair or EVAR, then it is not surprising that EVAR patients have better pain outcomes. However, the problem with EVAR is that the long-term quality of life is not as good as open repair, should the open repair patient survive. And this is mainly due to the complications related to endovascular repair, in which they can have endo leak, etc., and recurrent procedures. However, what is certain is that those who undergo emergency open surgery, aka ruptured aneurysms, post-operatively they have a higher risk of developing chronic pain. So there are not that much studies that look at the optimal anesthetic technique for repair. Of course, for when it comes to EVAR, both GA as well as local regional techniques are viable, And there have been some case reports looking at usage of paravertebral blocks with or without infusions for abdominal aneurysm open surgery. However, none of these studies actually look at long-term pain outcomes. They only just look at either at the feasibility of the technique for local regional, or they look at the short-term pain outcomes, which obviously would be better with combined regional anesthesia. And then there is the major study, which is the master study, which look at epidural anesthesia and analgesia and outcome. And in that major study, about 142 patients had open aneurysm repair. And in those patients who underwent aneurysm repair, just like in the whole study as a whole, those who underwent epidurals plus GA had improved short-term pain and respiratory outcomes. However, all other outcomes are the same, including mortality. And long-term pain was not something that was studied in this particular study. But even when you want to perform combined regional anesthesia in AAA surgery, then there's issue of acceptability, and because of the fact that AAA surgery, they are usually anticoagulated, and based on the fourth ASRA guidelines for neuraxial blocks, they are actually considered high risk as regards to regional technique. And when you look at the guidelines, they recommend for anticoagulation after puncture, it should be at least 1 hour. So of course, I don't think we have been giving heparin less than 1 hour after a spinal or epidural, but not that we practice it, but it is something to take note of. Because another thing is that there's always the risk of getting a dreaded spinal hematoma after administration of RA in a patient that is going to be anticoagulated. And this is especially true if, let's say, if you try to do a thoracic epidural, and then when performing it, then you get a traumatic epidural insertion, then your risk of spinal hematoma is much higher compared to all the rest, even though the overall incidence of spinal hematoma is actually relatively low. So if you get a traumatic tap when you get a traumatic insertion of epidural, then you are in a bit of trouble, and your surgeons may not be happy if you decide to cancel the surgery. So in our practice, we have been doing without RA, and there has been no evidence that the outcome is not good. Okay, so next is I'm going to talk about carotid endarterectomy. And for CEA, the landmark study is the GALA study, the general anesthesia versus local anesthesia study, which demonstrated there is no clear benefit of regional over GA when it comes to mortality, stroke, MI, or cost effectiveness. So both are viable. And as regards to most people will practice GA plus local infiltration. And a study by Rekasam and colleagues noted that when it comes to patient satisfaction between GA and LA, it's actually the same. Of course, when you give LA infiltration, there will be lower immediate pain. But for CEA, there's no long-term pain outcome that have been studied about. Next is revascularization procedures. So there's actually not much evidence regarding what is the proper pain management for revascularization. And one of the key feature of peripheral artery disease is that once patient have pain at rest, then it's considered critical limb ischemia. And then once they undergo revascularization procedures, and then if they have recurrent or persistent pain, so then which issue is it? Is it the pain due to surgery, or is it pain due to the disease itself, in which there's a worsening peripheral arterial disease. So this is something that is difficult to ascertain, and you have to see the patients. And when they look at epidurals for revascularization procedures, they found that epidural does reduce short-term pain outcomes, but there's not much evidence that it improves the other outcomes, including long-term pain. And again, you have to go back to the ASRA guidelines, in which there's always that risk of having a bleeding complication if you decide to perform regional anesthesia for revascularization procedures. And we in HKL, all our revascularization procedures are generally done under GA exclusively. So when it comes to limb amputation, there's a bit more robust in terms of the studies that have been done. Because obviously patients who undergo limb amputation, they have a high risk of persistent post-surgical pain. But ironically, they are also more difficult to do long-term studies about. And this is because a lot of the patients who undergo limb amputation, they have a much higher long-term mortality rate as compared to the other surgical populations. So there have been studies that have been done about preemptive analgesia, whether as a PCA or epidural. However, these studies have conflicting evidence when it comes to the long-term pain outcomes. However, when it comes to short-term pain outcomes, there's a clear benefit of using preemptive analgesia. And the same thing goes for intraop perineural catheters or LA infiltration. They give good short-term pain relief, but there's no clear evidence that it leads to better long-term pain. So next, we talk about the conversion of acute to chronic pain. And in vascular patients, they can be maladaptive inflammation and neuropathy, especially in our peripheral arterial disease patients with critical limb ischemia. And in any patient, the risk factors for conversion include high degree of acute baseline or preoperative pain, which is generally present in the vascular patients, especially those with critical limb ischemia. And there are some other factors like psychosocial variables, for example, pain catastrophizing behavior, or those with female sex and some genetic susceptibility. So a study by, I think they are siblings, Andre and Andre, found that there's no definite evidence that favors epidural and paravertebral analgesia for prevention of post-operative chronic pain. And this is based on meta-analysis that they've done on usage of those two methods to prevent chronic pain in the general surgical population. And when they did that meta-analysis, when they tried to look into amputations, they were actually unable to pool the amputation studies for the analysis due to the heterogeneity of the studies. However, they do recommend that because there's good short-term pain outcome, that preemptive analgesic strategies should be employed in those at high risk of conversion to chronic pain states, which is primarily our peripheral arterial disease patients. So what about chronic pain syndromes? So there are four that are important. One is the phantom limb pain and stump pain. Another one is CRPS. Then ischemic pain in peripheral arterial disease. And then lastly, thoracic outlet syndrome. So phantom limb pain occurs in about 50 to 80% of amputees. And there is peripheral as well as central mechanisms, which I've hinted to earlier when it comes to the mechanism of chronic pain. And as regards to the peripheral mechanism, is mainly from modulation of the efferent transmission, in which the transection of the nerve will result in regenerative sprouting of axons and then subsequent maladaptive responses to stimuli. And then along with that, there can be neuroma formation, and that leads to ectopic nerve impulses and neuropathic pain. Another mechanism, which I've hinted to earlier, is the sympathetic afferent coupling, which leads to sympathetically maintained pain. And then there's the central mechanism, which is characterized by the modulation of the efferent signaling, in which there can be reorganization of the dorsal horn neurons as well as the somatosensory cortices, and therefore leads to alteration of efferent signaling and subsequent phantom limb pain. And there can be some psychological factors, for example, pain catastrophizing can also lead to some cortical remapping, leading to central changes associated with phantom limb pain. So management of phantom limb pain needs to address both the peripheral as well as the central factors. In general, a lot of the proposed methods that can be used to manage are generally of low evidence. For example, like topical therapies, or botulinum toxin, or usage of TENS of the Stump. And as regards to central mechanisms, we can manage them with a lot of our anti-neuropathic medications like gabapentinoids, ketamine, opioids, topiramate, and also memantine. But what is also very important is the psychological management, which can be in the form of biofeedback, mirror therapy, mental imagery, hypnosis, as well as meditation. So McCormick and colleagues tried to analyze what was the best form of treatment as regards to phantom limb pain. And they found that as regards to short-term perioperative management, the best evidence is still IV morphine, but also IV ketamine. And as regards to long-term treatment effect, they do recommend oral morphine for that. However, there are other management modalities or have mixed evidence base. For example, the usage of perioperative epidural anesthesia, whether with morphine and LA, and as well as the use of gabapentin. So next is CRPS, which is itself a whole big topic in itself. But in summary, it is generally it has a complex pathophysiological mechanism with autonomic dysfunction causing marked changes in vascular reactivity. And the management generally depends on what the clinician feels is the dominant pathophysiological mechanism, whether is it due to changes in the peripheral nervous system or the central nervous system or the autonomic nervous system, or whether it is due to the other mechanisms such as immunologic, genetic predisposition, or psychological factors. And in general, the evidence base for the treatment modalities is actually not that strong. So the main key factor in the management of CRPS is physiotherapy, occupational therapy, and psychological therapy, alongside whatever intervention that the clinician is comfortable with. So proposed medical interventions include neuropathic pain medications, anti-inflammatory therapy, bisphosphonates, which is actually used for osteoporosis, sympathetic nerve blocks, and then other more invasive therapy like spinal cord stimulation as well as dorsal root ganglion stimulation. And there's also some studies trying to look at the proposed ability of vitamin C to actually prevent CRPS, for example, in those after wrist fractures. So next is peripheral arterial disease, which is probably the predominant patients that we see along with phantom limb pain. So the mechanism of chronic pain is firstly you have the atherosclerotic obstruction to the blood flow, which leads to reduced oxygen delivery, and that subsequently leads to muscle ischemia, and then increase in inflammatory mediators, which causes inflammatory pain, and then subsequent dying off and remodeling of the local nerve endings, which leads to peripheral sensitization. And then the cascade of the inflammatory pain will lead to subsequent changes in both the peripheral and the CNS, which leads to sensitization. And however, there's not much studies that look at what is the optimal management options for the pain management of peripheral arterial disease patients. For non-pharmacological, it is recommended for exercise during early disease. But once the disease has progressed and the ischemia is no longer intermittent but becomes constant, then we start we start giving the patients analgesics. And if the conventional analgesics do not work, there have been some study looking at spinal cord stimulation. However, at the end of the day, the main surgical management is to revascularize the limb. And if the revascularization fails, then definitive treatment would be amputation. But of course, amputation is not without its complications. And as regards to us, amputation can lead to a high risk of phantom limb pain. One thing that we only very rarely see, I've never seen, is thoracic outlet syndrome, which can be either vascular or neurogenic. Regardless of other interventions, for example, LA injections, exercise, physio, the best management modality of thoracic outlet syndrome is still to do a first rib resection in order to free up the space and relieve the manifestations of thoracic outlet syndrome. However, many still perform other conservative managements in order to try to avoid surgery, even though it may become inevitable. Okay, thank you. These are my references. The main reference is the review article by Seretny and Colvin, Pain Management, and the other references are all actually quoted by the same study. Any questions?
Let's talk about this the pain management for AAA surgery. So as per what you have presented, the use of epidural in AAA surgery offers good pain relief post-operatively, at least during the post-op period. So we had done epidural in our AAA patients long time ago. But like what you have alluded, the problem is when you have got traumatic epidural, then you be caught off guard. So to cancel the surgery, then is not something that we want to do in an elective AAA, right? So the issue is that say if the surgeon managed to do the revascularization very much faster before 1 hour, so you would need them to wait. So that's the thing. I mean, even without a traumatic tab, so you would want them to preferably wait 1 hour prior to giving the heparin. So in this manner, I mean, we can be caught off guard, especially if, say, your epidural procedure didn't go smoothly. So we had a discussion with the vascular team, and then we thought that it would be best appropriate to just use intravenous opioid as the modality of choice to avoid all these problems associated with epidural insertion during this specific vascular surgery. All right. So the other issue is that with an indwelling catheter in the post-operative period, a lot of times the patient would need to be started on antiplatelet quite soon after the surgery. So if the antiplatelet, for example, things like clopidogrel has been put on, so then you would have problems removing the catheter after that. So you can be caught this thing off guard as well. Say if the epidural catheter has not been removed prior to them starting it. We have got cases like this before, and so after discussion, then we thought that the most appropriate technique would be using IV opioid, where you in long-term outcomes there's not much of difference. All right. Any questions? So regarding this complex regional pain syndrome, we need to be careful with the diagnosis. So whenever there is a diagnosis of CRPS in a patient with peripheral vascular disease, we need to look at our normal diagnostic criteria for CRPS, which is using the Budapest criteria. So a lot of the significant autonomic manifestation or dysfunction is quite apparent in this type of patient. So one of the diagnostic criteria for CRPS is in the absence of any specific cause, that you cannot find any cause, and patient is manifesting this type of symptoms, then you would say that the patient has got CRPS. But a lot of times in patients with peripheral vascular disease, there is a specific cause as to why the patient is having pain. So you need to differentiate properly whether it is a neuropathic pain secondary to the peripheral vascular disease itself, or is it another new symptom by itself. That means the patient is developing complex regional pain syndrome. All right. Any questions about, say, phantom limb or anything that you want to ask regarding vascular surgery? Amir?
I think my only comment is probably when in one of the papers they actually recommended use for morphine for the phantom limb pain for the amputation surgery, because I don't think I mean giving patients for non-cancer pain for long-term opioids is not something, even though it may be effective, but it can cause other problems related to the opioid epidemic.
Yeah, I would agree to that. So for us, most of the time we would try to refrain ourselves from using long-term strong opioids, especially in chronic non-cancer pain. So need to differentiate between neuropathic or nociceptive. A lot of the patients with phantom limb pain in specific need more of anti-neuropathic rather than strong opioids like morphine. So at least in our experience, we are able to control the patient's phantom limb pain using a combination of different type of anti-neuropathic agents. So I wouldn't agree to using strong opioids in this group of patients. Yeah. All right. If any other questions, any other thing that you want to bring up, Amir?
I think that will be all, but I think it's quite interesting that for even though we see a lot of the vascular patients, the evidence base is not that strong, and for what we do have, it seems that there's no clear winner as regards to what is the best modality to manage patients.
Yeah, in the end, it is still proper assessment of the patient. And then, as what has been alluded in the presentation, there can be coexisting nociceptive as well as neuropathic pain in patient with peripheral vascular disease in specific. So long time ago, we have been focusing a lot on nociceptive pain, and there was not much of a focus on treating neuropathic pain, but the experience, I mean, at least in our center, shows that a lot of them has got coexisting neuropathic pain as well. So you would be giving large doses of strong opioids and the patient is still having pain. So after optimizing all our anti-nociceptive as well as anti-neuropathic, if the patient is still having pain, i.e. due to ischemia type of pain, then we need to tell the surgeon that there is a limitation as of to our pain control. I mean, the same thing like a patient having chest pain secondary to severe triple vessel disease. So there is only to a certain extent you can relieve the pain, but in the end, the definitive procedure is still revascularization. So we will need to discuss with them and let them know lah. So this is the extent that we can provide the pain relief. So they probably need to think of a definitive procedure in the event that the patient's pain is not controlled. In specific, the ischemic type of pain that the patient is having. All right. Okay. All right. Okay. Thank you very much, Amir, for your nice and detailed presentation. All right. That's all for today. Thank you very much. Okay.